Over
Today
to you,
the
Vinaya.
SLOs, yeah, thank you, sir. Today the SLOs in hepatobiliary will be taken by Dr. Malini Aipan. She is a professor from Amrita Institute of Medical Sciences, Kochi, and her areas of interest are in hepatobiliary and dermatopathology. Over to you, madam, please.
Thank you, Dr. Vinay. I think you've been really spearheading the whole thing along with Dr. Sanjay. And finally, I had to take the plunge and do this. So I'm going to start now. And due
But it
acknowledgements
was
to Dr. Tejas,
rewarding and very great, madam. Yeah,
and to you
your
definitely.
experience will help us. Yes,
I've
madam.
used some of their inputs also into the SLOs created. Yeah, so I'm starting out. Oops, sorry. Yeah. So these are the broad SLOs that have been given for the hepatobiliary system, which is number of competencies are 6 and procedures that require certification 1. So I just go through each one separately. So coming on to the first competency, which is describe bilirubin metabolism, enumerate the etiology and pathogenesis of jaundice, distinguish between direct and indirect hyperbilirubinemia. So the SLOs under this would be 1, define jaundice and cholestasis. For that, it is the knowledge, the domain is knowledge, and it's knows. Core is yes, core competency is yes. And I thought that probably would be a lecture, with the assessment model being a theory, which could be either a short answer question or framed as an MCQ. The next part is outline bilirubin metabolism and bile formation. Again, knows how, core competency, yes. And lecture, probably sharing with biochemistry, because there are a few biochemistry SLOs competencies also which kind of overlap with this. Again, the mode of assessment would be theory or viva. Types of jaundice and its pathophysiology. This is knows how, yes, is the core competency. I thought probably it would be better to have it like a small group learning, nesting it with general medicine. Again, there are core competencies in general medicine, which I've outlined over here. And the assessment model again would be theory, which can be a case-based question, short answer question, MCQs, or as a viva format. Then the causes of jaundice, again, the same applies to all this, with it being a core competency. Small group learning, nesting again with general medicine, and the mode of assessment would be theory, which is a short answer question. Then lab findings in different types of jaundice, which is knows how, and shows how, which is, I guess, interpretation, and core competency as part of the small group learning. Again, I thought probably we might have a correlation with medicine, because nesting is where you cover the aspects. Correlation, probably we have a medicine person along with us, or it can be as a self-directed learning. Again, theory / viva. Before moving on, is there anything to be added on to this? So I put it as lecture 1, small group learning 1, SDL 1. Actually, small group learning will be 3 in this. I've just clubbed it as 1 because it's to show the amount of time. Sharing with biochemistry, nesting with medicine. Is there anything that needs to be added or deleted in this? Or shall I move ahead?
Yes, madam, move ahead.
Yeah.
Yes, ma'am.
So the next one says describe the pathophysiology and pathologic changes seen in hepatic failure, the clinical manifestations, complications, and consequences. So in this, I've broadly categorized it as 1, types of, the student should know the types of liver failure, which is again as a lecture, correlation with general medicine. Again, I put the general medicine competencies also here. And the mode of assessment would be theory, which is again case-based or short answer questions, or in a viva format. Define acute liver failure, again as a lecture, correlation, general medicine, and theory / viva. Causes of this lecture one is because I have used that particular hour also to cover jaundice. So I've just clubbed it as lecture 1. I'll tell you why I've done that when I come to the hours. Then causes of acute liver failure, again as lecture 1 or as a small group learning, with correlating with general medicine. Again, mode of your assessment would be theory, I suppose. Clinical features, again as an SGL, with correlation with biochemistry and general medicine. theory, which can be a case-based or an MCQ or a short answer, and or in a viva format. Then morphology of acute liver failure, which is as a lecture, I thought probably it's better that we discuss the morphology. Again, as a theory, which can be a case-based or a short answer question or in a viva format. Then the complications of acute liver failure. So I've put this into 11 SLOs. So if anything needs to be deleted or added on, you can tell me. Lecture, correlating with physiology, I've put the physiology competency here and general medicine. So again, theory, case-based or short answer question, or viva as the mode of assessment. Define chronic liver failure and cirrhosis. Lecture 2, so we start with a new hour that time. Theory is the mode of assessment. Mechanisms of injury, again as a lecture, probably can have it as in a seminar format. Again, mode of assessment would be theory. Causes of chronic liver failure, again as part of the same lecture, correlation with general medicine. The competencies are put here, and theory/viva as the mode of assessment. Clinical features and clinical syndromes of chronic liver failure as a small group learning, correlation with biochemistry and with general medicine. Again, theory with which is case-based, MCQs, short answer questions, or in viva format, and the morphology of chronic liver failure, which is again a lecture, and the mode of assessment would be theory/viva. So here it includes lecture 1 and 2 because that's the hour that I've utilized. Small group learning as 2 and 3 because there will be 2 small group learnings, and correlation is with biochemistry and with medicine departments. Anything to be deleted from here because
Dr. Lanjewar, sir, please unmute yourself. He has written nesting can be done with pediatric and OB-GYN.
Okay, so I'll add that on later. So I'll just note down the points and I'll add it on later when I'm sending.
Sir, Dr. Shagufta wants to say something. Please unmute her. She has written on the, yeah.
Where is she? Yes, I found her. Yes.
Good afternoon, ma'am. Am I audible?
Yes, yes, ma'am.
Okay, ma'am. Ma'am, regarding the first competency that madam was discussing, the first one that define jaundice, is that just one SLO for one lecture? I couldn't get it clearly.
No,
define jaundice.
that's why. No,
So
which is why I put lecture 1. That particular topic will be covered in the first lecture. This one, there are a couple of lectures. If you want to the next page also, you will. I'll tell that finally when I'm listing it out.
Okay, that's fine, ma'am. But regarding this outline, bilirubin metabolism, this and bile formation, this should exclusively be done by biochemistry people. So this is integration, horizontal integration with biochemistry. We need not do this because what is in pathology about bilirubin metabolism and bile formation?
I think we need when they come into pathology, they really need to know, no, bilirubin metabolism,
yes,
because
you are right. They need to know, ma'am. But who should be the one doing this, ma'am? I mean, I'm not very well versed. If I'm teaching hepatobiliary, I'm not really very well versed with bilirubin metabolism. Even at this, I have to go back and read the entire. Have you been teaching? I'm just curious. Have you people been teaching bilirubin metabolism and bile formation?
I have been teaching bilirubin metabolism when I take hepatobiliary, because you really go back into the biochemistry, hoping that they know some of it, but you can add on to what you're teaching.
That's right, ma'am. That's what I'm trying to say basically, because now if you are in CBA, if we are in this new phase of curriculum, we have to outline what we are going to do and what others are going to do. And that's precisely, I think, one of the objectives here. So why don't we give this part completely to the biochemistry people and write integration with biochemistry? Just my opinion.
Yeah, wouldn't that be a sharing then? Sorry. Wouldn't
yes,
that be
sharing
a sharing?
of your hours.
Put it as
yes, Definitely sharing of your hour, because you see you already have very small learning objective, that is define jaundice and cholestasis. So that will not take you much time. You can give rest of the time for the biochemistry people to come in and take over.
I think he has
So
already
you're saying
written
it should be done.
sharing. She has already written sharing biochemistry. Outline bilirubin metabolism and bile formation. The word sharing
Dr.
is
Sanjay, I think what Dr. Shagufta was trying to say is that when you're saying sharing, then it means that you're giving your hour to the biochemistry people. I guess that's what she was trying to say.
Yes, true.
Right?
Right.
And you're losing
Right.
out on your hour. That is the question here. But then it will be done in the first year. So it will be biochemistry hour. Then probably 6 months or a year down the line only they'll be coming into pathology. Even what we teach
So-
the previous day, they don't remember the next. So shouldn't there be a reinforcement somewhere?
Yes, that's right, ma'am. So, for example, when we are discussing curricular mapping, as you said, you take the first part of your lecture, or you do your related part, and it will be followed by a biochemistry lecture on bile formation and metabolism. So that will give the integration, and student will make more sense of it, and then you go to your third topic.
Okay, fine. So instead of sharing, I put it as integration with biochemistry. That's what you want, right?
True.
You want the
That's
biochemistry
right, ma'am.
people to do using their hour. Okay, fine.
Yes,
So
ma'am.
shall I do that then? I'll correct it. And, yeah. Okay. Shall I move on to the next slide then? Is there anything here in
Yes,
the
ma'am.
next PA 25 point? Anything to be done here? Because
Yeah,
this I
you
thought
can
was
go
too
ahead, ma'am.
extensive. Yeah. Okay. Fine. So the next competency is describe the etiology and pathogenesis of viral and toxic hepatitis. Distinguish the causes of hepatitis based on clinical and laboratory features. Describe the pathology, complications, and consequences of hepatitis. So under this, I've put the SLOs as what is hepatitis, which is a lecture, and the assessment model can be theory or viva. Causes of hepatitis, like a broad categorization of what are the causes, again is a lecture, theory or viva being the mode of assessment. Types of viral hepatitis, with a note on hepatotropic and non-hepatotropic, which I thought may be better as a small group learning. And the mode of assessment can be theory with or viva. An overview of the viruses and serologic patterns. So here I've put sharing with microbiology because I'm assuming that the major bulk of it is done by the microbiology. But if you want me to put us integrating it with microbiology, utilizing their R, then let me know towards the end. Then clinicopathologic syndromes of viral hepatitis. This I thought correlation with general medicine. So it can again be done as a small group learning. Morphology of viral hepatitis with clues to the virus, since undergraduates don't need too many details, at least a few pointers to what the viruses could be based on the morphology. Again, can be either a small group learning or a self-directed learning. Mode of assessment would be theory and viva with pictures, I thought, probably flashcards or something of that sort. A brief note on bacterial, viral, and parasitic infections, which again can be a small group learning. Sharing with microbiology, I've put the specific competencies in microbiology, or it can be a self-directed learning. Because here actually it's not there as part of this one as the main thing. So I don't know what the core competency of this would be, whether it would be a Y or a N. So the other one is a basic idea about autoimmune hepatitis. Again, as a small group learning, correlation with general medicine. The competencies are put here. And should know the entity, drug bar toxin induced hepatitis. Again, as a small group learning, correlation with general medicine. And in these cases, since I didn't know whether it was a core competency, I have put it as viva, as the mode of assessment being viva. Is there anything to be added, or can I scrap all this? Because I thought autoimmune hepatitis, definitely they need to know. Also drug-induced hepatitis.
Ma'am, just I have a question.
Yep.
Hello. Ma'am, regarding number 7, a brief note on bacterial, viral, and parasitic infestations. Is it part of the competency, ma'am?
It's not. I have just put that because I thought when you talk about hydatid cyst, amoebic liver abscess, this is something that they may sometimes encounter in the clinical scenario. So I have just added that. That's not part of the core competency, which is why I have not put it as a Y or an N here. On the core competency, I've just left it blank because I really don't know whether the undergraduates need it or not. It's not been mentioned.
What I'm trying to say is that we are inducing, you see how many now, these are around 9 ILOs. So how many lectures for these ILOs?
I thought for hepatobiliary system, the number of hours was 10 hours, right? Including your DOAP. Or is it lesser than that?
10
10
lectures.
hours is what I thought. Yeah, 10 hours basically. You can split it into lectures or small group learning. That's what I understood it as. I'm not sure.
I mean, I don't have a problem with introducing that ILO personally, but what I'm trying to say is that we are unnecessarily inducing things which are not there in the competency, that is making it more lengthy and extensive, our curriculum. And students basically running away from such extensive curriculum. They just want something focused and what they are going to use. But as you said, some of the infections are very important. For example, hydat is very common in India, amoebic liver abscess and all of that. I agree with you. Maybe you can leave it.
Hello. Dr. Ajit, are you there?
Hello.
Hi. Yes, sir.
Yes.
Dr. Lanjevarsan.
Can you keep separate amoebic liver abscess, pyemic liver abscess, and hydatid cyst? Don't include it here.
Where do I put that, sir?
Because this is all viral hepatitis you are covering, no?
No, it's both viral and infectious. Basically, this is the competency talks about viral and toxic hepatitis. So where do I put this? Because there is no other, there is no competency specifically mentioned for this.
Okay. The liver, where liver cirrhosis is included? Liver cirrhosis, hepatocellular carcinoma.
That's not included, sir. No, liver nodules and gallbladder are not there in the competency.
Liver cirrhosis is also not there?
Liver cirrhosis as part of that was there in the previous one. So I'll just go back to the previous one just to show you that. That is when we spoke of the chronic liver failure, the 7th one, and cirrhosis. There you're supposed to talk about the mechanisms of injury and repair.
Okay.
And the clinical syndrome. It comes as part of the.
So
okay,
then we can make a chart of this hydatid cyst and amoebic abscess, multiple abscesses of a toxic specimen can be made a chart and discussed in the small group teaching during DOP.
Yeah, that's what I put. Yeah. I put as a small group learning and I put as Viva. So probably with flashcards or picture quizzes or something of that sort.
Or those who have specimens, they can show the specimens.
So I have not put the core competency for the last 3 because it's not actually defined in the the main competency.
Okay, ma'am.
Yeah. So what I'll do is over here I'll say Viva as a picture quiz. So I put it as small group learning, population and sharing. Shall I continue it like that, or there any changes need to be made here?
Ma'am, you can highlight these 3 that you are mentioning that you added out of the competency as recommendation. You can highlight it as a recommendation. Just add a note, recommendation, and highlight it in yellow. Use a highlight, so that will be your recommendations. And as Dr. Sanjay said, that he will be discussing those important recommendations with the MCI directly, and they might just include it.
Okay. Can I move on? Dr. Ajit, are you there? Dr. Lanjavar, can you unmute Dr. Ajit Nambiar from Amrita?
Yeah. Sir, Dr. Ajit Nambiar to unmute.
Sir?
Sir,
Unmuted. I have asked him self-muted. Dr. Ajit, please unmute yourself. Yes. Yes.
Yeah. Yeah. Hi, Vinaya. Hi.
hi, how
Hello,
are you?
Lanjavar
Fine.
sir. I'm fine.
Hello.
Hello, sir. Yeah.
Good.
Hello.
No. So I was just thinking, on jaundice and both what bilirubin, which metabolism, which Malini was talking in the first slide. They could be in a small group teaching where you actually kind of revise it or kind of put a case history in which you try to get it out from them, because these are all kind of as Malini said, these are very important things that a student should know, and all our duty is to kind of revisit them through a case where we actually try and get it out from the student rather than teaching it as a competency or ILO. And even this pyemic abscess, hydatid cyst, I don't know how it has been missed out. I fully agree with Malini that it should be there, and therefore could there be an SDL or something on that?
Yeah, possible.
Yeah.
That's a good thing. Actually, with case-based only, we can re-emphasize the importance of types of jaundice. Otherwise, they always get confused whenever we give them chart
Mm,
to,
mm.
so that is actually very important, because these parts, they also form a part of your LFTs. So both can be, taken in hand and emphasize the concepts very properly. I agree, Ajit.
So what
Dr.
I'll do is
Tharmal
I'll put that point number. Yeah. So
Yes.
I'll make that point number 2 of the first competency instead of a lecture 1, I'll make it SGL, small group learning, right?
Okay. You can do it later, madam. You can finish up the SLOs,
No,
and
I'm
after
doing it now.
rectification.
Yeah, I'm doing it later.
Okay, ma'am.
So that this is the next competency, which is describe the pathophysiology, pathology, and progression of alcoholic liver disease, including alcoholic cirrhosis. So I thought the first one should be metabolism of alcohol and the pathophysiology of alcoholic liver disease, which can either be a lecture or as a small group learning. Clinical features of alcoholic liver disease, which can be a small group learning with case-based and correlation with general medicine. Morphology of alcoholic liver disease, probably as a lecture, because there are some pointers and clues in the histology and the gross. So probably as a lecture. And progression of alcoholic liver disease as a lecture, and nesting with general medicine. I've given the specific competencies in the general medicine part also. Assessment is theory bar viva for all of these. One thing that I didn't find in this lot was non-alcoholic fatty liver disease. So that is not there anywhere in the competencies which have been already said. So is there anything to be added, deleted in this particular
Madam,
aspect?
Thamil Selvi wanted to say something, madam. You can unmute. She has raised her hand, Dr. Thamil Selvi.
Please unmute yourself, Dr. Tharmal. Yes.
Yeah.
Audible,
Yes,
sir?
madam.
Audible?
Yes.
Yeah.
Yes,
Good
audible.
afternoon, sir. Good afternoon, ma'am. Ma'am,
Yes.
regarding the liver, the failure, the bilirubin metabolism can be given as a small group learning, okay, or SDL, self-directed learning, like that we can give and come out with, as said, we can do that. Okay. Hello.
Hello. Yes, sir. Yes, ma'am.
Regarding the competency, everything discussed, ma'am, or second competency now only it has come?
Yeah.
Liver.
Yeah.
Okay. Okay. At the end, I can have something.
Okay,
Okay.
madam.
Thank you. Proceed. Proceed.
In this particular thing, is there anything to be added, anything to be deleted? Because I thought all this were important, because alcoholic liver disease comes as a case-based question, as short notes. Is there anything else to
Ma'am,
be added in that? And I thought,
you can
sorry,
add, as you said, non-alcoholic liver disease.
fine, okay. So I'll add that into this
So
also.
that would
But
be
I
a
don't know how
recommendation.
far we need. Yeah, but I don't know how far, because with non-alcoholic fatty liver disease, then you have to talk about insulin resistance and all that. So I don't know how much of this undergraduates will actually need. Anyway,
But
we'll
actually,
see that.
we seeing
Sorry?
that we're seeing that pattern more commonly now. So we
Yeah,
have to keep
yeah.
students on track. I mean, kind of, they should know about this particular entity as well.
Yeah.
So shall I put it in as a recommendation towards the end?
Yes.
For
Yes,
top?
please.
Yeah, okay, fine.
I
Can I
think
move on to
so.
the
Tamisani,
next
you
one?
wanted to say something, madam? You
No,
have
ma'am,
raised your hand,
last
madam?
I will add. Last I will add,
Okay.
ma'am, not now.
Okay, madam. Okay. Okay.
Can I move on to the next one?
Yes. Yes, Dr. Malini.
This is the next one, which says describe the etiology, pathogenesis, and complications of portal hypertension. Again, I thought it was a very clinically oriented topic, but I just split it up as define portal hypertension. What are the causes of portal hypertension, pathogenesis, and the complications? So the core competency is yes for all of them. And I thought probably it may be better as a small group learning or a self-directed learning. So in this, I have not put it as a lecture. I thought it may be better as a small group learning, sharing with general medicine and nesting with physiology. Probably adding radiology also to it, because there are so many parameters that come with radiology also, measuring the portal venous pressure and all that. So I thought probably correlation with general medicine and radiology. So this can be done either as a small group learning or as a self-directed learning. But it is a core competency as per the MCI, the curriculum.
Yeah, I think so. It is the most important competency, in fact, which the students more often will encounter when they go into the clinical field in medicine.
But it's very
In the ward.
clinical. There is nothing pathological about it. That was my issue here. Anyway, this will
Pathology,
do
when
for
we
that,
have
right?
pathophysiology, explanation of the portal hypertension is purely pathology. So that explanation with the schematic diagrams, proper diagrams can be explained. So then immediately all the clinical features should come in front of them. So the pathogenesis plays an important role. That is definitely our field.
Okay, fine. So shall I move on to the next one? If there's nothing,
Yes.
I don't need to add anything to this, right?
No, madam. Okay.
I can maintain it. I've not used it as a lecture at all. So I thought maybe
Yeah.
better as a small group with the clinical
Yeah.
scenario.
Yeah.
Yeah, could be mode of assessment mostly as theory, but like a case-based. So theory of Viva as a case-based kind of learning.
Yes, ma'am.
Moving on to the next one. Interpret the liver function. This is a DOAP. Interpret liver function and viral hepatitis serology panel. Distinguish obstructive from non-obstructive jaundice based on clinical features and liver function tests is what is being given there. But I guess urine also will come into the picture, right? Or does
Yes, it
urine
will
come
come, madam.
separately with the, yeah,
Yeah.
so I have not added that because it's not there in the competency, because they're speaking specifically about the liver. Now I don't know whether when you teach urine, whether that comes as part of a competency in urine.
Mm-hmm.
So in this, I've broadly categorized the whole thing into should know how to interpret the LFT, should be able to distinguish the different types of jaundice, interpret the serologic patterns in viral hepatitis and its translation into clinical practice. So they need to know what is negative, what do you consider that when this is negative and that is positive. So that is the translation to the clinical practice. And this is your observe, do, observe, assist, and perform. So that is, I think, as described in the previous one itself, as something that you perform or you do, and the pathologist or the examiner observes. So is there anything else to be added on to this?
So, ma'am, what do we plan to show them? Are they going to see these tests or what, perform them or what?
No, they will not be performing these tests, no. It will only be interpretation of the tests and the charts, right? It will be like a visual interpretation. We don't make them do the LFT, no.
No, we don't do. But during this DOP, can we keep some specimens like cirrhosis, which is easily available? We can include that, recommend that. And yeah, so rather than, and all this will be the clinical charts, interpretation.
Yeah, clinical charts. Yeah, clinical charts and serology charts.
Yeah. So
between obstructive, non-obstructive jaundice, basically.
yeah.
Yeah.
So because we want them to differentiate based on the test. Based on these tests, we want them to differentiate between obstructive and non-obstructive jaundice.
Yeah.
Yeah. So shall I add on to the DOAP? I'll put it as charts/specimens.
Yes, ma'am.
Yeah.
Please,
Yeah.
please.
I'll add that also. Yeah.
Yes.
Can I move on to the next one? Okay, now these two competencies I've written as extras because they were not there, because we finished all 6 competencies given by the curriculum. Now this was not there in that. So I thought this is one portion that we do teach them. So I'm not very sure. So cholecystitis, the types of gallstones, the risk factors, pathogenesis, clinical features, morphology, and a brief mention about gallbladder carcinoma. So since I didn't find it as a core competency in the curriculum, I thought probably a small group learning or a self-directed learning should be enough for this. What are the thoughts on this? And the assessment mode can be a case-based, because cholecystitis can be as a case-based. You can have pictures with gallstones, specimens with gallstones.
Again, it's a very common problem, ma'am. I don't know how MCI has missed out on gallbladder.
Yeah.
You can put this as a recommendation because this is very important.
Fine. So shall I move on then to the next one?
Yes, ma'am. Dr. Tamil
So
Selvi,
this
you
is
want to
also
say
an
something? Okay. Acha, tumors are not covered. Oh, okay.
No. So this I've put as classification of liver nodules in general. A brief note on hepatocellular adenomas. Should know the entity hepatoblastoma. Causes, clinical features, and morphology of HCC. Should be familiar with cholangiocarcinoma. So only this I thought should be a core competency, the HCC. The rest, okay, it need not be a core competency, but they should be aware that there's something like this. And this side, I've put it as lectures, because I was not sure whether self-group teaching or small group teaching or a self-directed learning would actually be a feasible idea in this scenario. I was not very sure, so I put it all as lectures. And here I put correlation in HCC, I put correlation with radiology and surgery.
Actually, madam, when we are taking cirrhosis and teaching them about the complications of cirrhosis, so the incidence of complication, one is important is hepatocellular carcinoma. So with that in view, can't it be taken there and along with the specimen one HCC and metastasis? Well, metastasis is also very important. When we take a neoplasia, that is a specimen we show, liver and lung are the common sites of metastasis. So whether that can be shown with specimen and included in that.
Ma'am, instead of cholangiocarcinoma, you can add the secondary tumors of the liver because that's more common. Liver and lung are the most common sites of secondary tumors, and actually in these two organs, secondaries are more common than primaries.
Yeah.
So you have to put the one SLO for the metastatic tumors. I think cholangiocarcinoma not required for undergraduate. I don't know what others think, but I think
it
it's
is
a
not required,
postgraduate.
madam. Yeah, I agree with you, Dr.
So we
Shagupta. Generally, we don't show cholangiocarcinoma, but we definitely show multiple metastasis in a liver as a specimen.
That's very
survivor.
important.
Yeah.
You're right. You're right,
Yeah.
ma'am.
So I'll scrap the cholangio and I'll put metastasis.
Yes, madam.
Over there. And about the what is the methodology? Can it be lecture or should we add a small group learning? Because I'm not very sure whether small group learning in this particular thing would help.
Actually, it can help actually, madam. Because as a part of complication, HCC and multiple, we can be reinforced through some small group teaching or some through cases, definitely.
Okay. So HCC, I'll put it as small group learning also.
Yeah.
I'll add on small group learning to that.
Yeah.
Okay. Can I move on to the next one? I think that we come to the end of that. And these were my queries. So NAFLD, then all these metabolic diseases, hemochromatosis, Wilson's, it's not come anywhere. So what are we supposed to do with that?
Ma'am, what is removed is removed. My opinion, please don't overburden the students. They're already running away from our curriculum.
Hello.
Yeah.
Can I say something? Hello.
Yes. Yeah.
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 We can hear you.
Yeah. Yeah, no, we have been saying, Dr. Malini has brought in all these points, and if you look at, we are also training them for the NEET exam. If you look at the NEET pattern nowadays, you will find all these questions there. So when do the students actually gain that information from us? Unless we give them an SDL or make them understand that these are also relevant questions, because the scale of the exams in NEET is very high standard, and it includes all these questions which Dr. Malini has raised.
Yes, I agree,
Can
actually.
can I answer that, ma'am?
Yeah,
Can I answer
please,
that?
madam. Yes.
Sir, I completely agree with you. One of the main objectives of this curriculum is to prepare the students for the NEET exam. But if you'll appreciate the NEET exam, it covers a whole lot of topics which are not included in our curriculum, present curriculum. And if we go on adding the entire thing, then I don't think we will be able to complete in the number of hours that we have been allotted for pathology. We won't be able to cover the entire curriculum. So the question about NEET is that the pattern of NEET, we have to be able to prepare our students to be able to score well in NEET. So that's basically the differences in the assessment types that are being used in the undergraduate and in the postgraduate. I think that takes care of the NEET part. If we change our assessment strategies and train our students to take the kind of questions that are asked in NEET, we can do that as an additional exercise. I agree with you. But to include the entire topics that are there in the NEET, then it's the entire book, the entire Robbins that we have to teach them in the limited time that has been assigned to pathology. We have to think about the time constraints as well. That's my opinion, sir.
The problem is this pen is never taken anywhere. So they'll be clueless.
Or another hello.
Yeah. Yes,
Yeah.
yes, sir.
Another
We can
thing,
hear you, Doctor.
yeah. Another thing is, this is all about, all nesting, integration, and all, or the medicine departments or the surgery departments, when they are taking this, should either teach that themselves, or call us. In the UK, pathology is also taught in the final year, for the simple reason that students are much better prepared to understand. Nowadays we take lectures for interns. It's not lectures, but we do some neat questions with the interns, and they are much better equipped to understand those questions, because they've gone through the clinical. So sometimes I think I don't know whether the MCI would take this as a positive suggestion, that at times a pathologist comes in in the third year, in the third or fourth year, and reinforces certain things, where at this point in time, such things, even a student will be more ready to assimilate these things.
I agree with you, sir.
That's true, Doctor.
Very well said, sir.
Absolutely right.
Very well said. We need to put that recommendation to the MCI, and in many countries, even when I was in Saudi Arabia, we used to go and teach in the clinical years. And it's a global practice because we are starting in India now. So hopefully in the near future, we will be integrating ourselves with the clinical people. And then that will break the barrier actually between the basic and the clinical sciences. And it will bridge that gap which we have with them. And it will build a better rapport. It will build a better rapport for the curriculum.
Yeah.
Development.
I'm a big proponent of the point that pathology is not a paraclinical subject. Pathology is a clinical subject, and I think we have to break out of this paraclinical word for pathology. Pathology
It's
is a
only in
clinical subject.
It's only in India. If you talk about
Yeah,
other
I mean
countries,
that's why
branch.
I want all the group. I want the group to kind of put this up, that pathology is a clinical subject. It should be, it's the same thing like radiology is considered to be a clinical subject. Pathology
Absolutely,
is not supposed to be.
absolutely.
I can't understand that. So I think we should,
Absolutely,
as a
it's a
recommendation,
core
put it.
clinical subject.
I
Absolutely, I
agree with
agree
you,
with you,
Dr.
sir.
Ajit.
I mean,
Hello.
there is a integration curve which has been provided by MCI, in which they say that in the initial years, basic subjects are more and clinical subjects are less. But as we move forwards, the clinical subjects are more, but that does not end the paraclinical and basic subjects even in the final year. In
Yes,
the book that they have provided, they have created a curve. There is a curve diagram there. At present, I don't have it, but there's a curve. But they have definitely included that in the recommendations, that paraclinical as well as some basic have to be there even in the final years. So maybe that is change. That change is thought about, but we have to implement it.
Dr.
Hello.
Sanjay, can
Sir.
I just say something?
Hello,
yes,
Dr.
Dr.
Lanjewar.
Sanjay,
yes,
Yes,
Dr.
sir.
Lanjewar, sir.
This non-alcoholic fatty liver disease, do we have a topic of intracellular accumulation fatty liver where we can teach them intracellular accumulation? I think it must be there.
During that cell injury, we do teach them in general pathology, fatty
No,
liver.
intracellular accumulation. There is one topic. The
Yeah,
second,
Yes,
hemochromatosis. Hemochromatosis can come in a pigment disorders.
yeah.
Hemosiderosis and hemochromatosis. Alpha-1 antitrypsin deficiency can come in a accumulation of misfolded protein. Again, intracellular accumulation. What remains is the Wilson's disease. That we have to take care of somewhere.
Okay, so shall I put it in as a recommendation when we are
Yes.
putting the curriculum?
Yeah, put it.
Yes.
Put it.
Yes. Yes.
Okay, sir. Okay, thank you, sir. Shall
Yes,
I move on to the next one?
Number of speakers.
Yes, madam. Yes. Hello.
Can I move on?
Yes.
Can I move on?
Yes,
Okay.
yes, Dr.
So
Malini.
this is just encompassing the whole thing. So I've put as total number of competencies as given in the undergraduate curriculum is 6 plus 2 add-ons, which is the gallbladder and the liver nodules. I'll probably add those as recommendations along with the others. Then in this, the first competency, which is about bilirubin metabolism and jaundice, I've put as lecture 30 minutes, small group learning 30 minutes. And the sharing is with biochemistry, so it will be integration or sharing, and small group learning is nesting with medicine. In the second one, which is the pathophysiology and pathology changes seen in hepatic failure, I've put lecture 1 hour, small group learning 30 minutes, correlation with biochemistry and medicine. The third one, which is the viral and the toxic hepatitis, I've put lecture 30 minutes, and I've put more of small group learning in that for an hour, sharing with microbiology, correlation with medicine. Then the fourth one, which is your alcoholic liver disease, I've put lecture and small group learning combined together for 1 hour. And the nesting and correlation is with general medicine. The fifth one, which is describe the etiology, pathogenesis, and complications of portal hypertension, is self-group learning for an hour, sharing and correlation with medicine, and nesting with physiology. And the last one, which is your do, observe, assist, and perform, interpret the liver function test and viral hepatitis. So that is as I put it at an hour. And the others which were not added on, which is your etiology path with the gallbladder diseases, I've put a small group learning for 1 hour, and sharing with physiology and correlation with medicine. Tumor nodules of the liver, lecture 1 hour, correlation with radiology and surgery. So this is the thing, and your total, oops, sorry. So the total number of hours, I think, comes to now, it is lectures 3 hours, 3.5 hours, I think, small group learning 5 hours, and your do, observe as 1 hour. So it comes to 9.5 hours. But if a couple of things go with biochemistry and with microbiology, then probably this can be reduced. Somehow I had a feeling hepatobiliary system was given 10 hours. I'm not sure about that.
Yeah, we'll see that, madam, when I'll check it out.
Yeah.
Yeah.
Anything to be said here? Because then I'll move on to the case-based slides. I think Dr. Tamil Selvi had some points, no? So,
Madam, unmute yourself, Dr. Tamil Selvi, madam. Yeah.
Hello, audible?
Hello. Yes, madam.
Audible,
Audible.
ma'am?
yeah.
Okay.
Yes, madam.
25.2
Yeah,
and 25.4 together we can take, ma'am. Hepatic failure together with the portal and portal hypertension together we can take it as either integration or by lecture we can club together, ma'am. Hepatic failure along with the portal hypertension. We can club together and we can add up, as you said, there is no gallbladder lesion given here, that we can be 1 hour lecture. Then hepatic tumors will be 1 hour lecture, or with a sharing or integration, we can take that too, both, ma'am. Okay, either 1 hour lecture with the integration. Okay,
So
then gallbladder
should
cannot
I
be
go?
given as a small group learning, ma'am, because it is new. They should know. Hello.
Hello.
Yeah, small
We cannot give as a
learning will
small
be
group
assisted
learning,
by
ma'am. Gallbladder have to 1 hour lecture or by integration we have to take, ma'am. Okay, ma'am.
So you mean to say this 25, I put this on screen, the 25.2, you want me to add this portal hypertension along with defined chronic liver failure, portal hypertension and cirrhosis?
Yeah. Together,
probably add that.
25.2 and 25.4 together we can take it as. Total number of competency given here, hepatobiliary system is only 6, ma'am.
Yeah.
But in that they are not
6.
included the gallbladder, not included the liver tumors.
Yeah.
That we have to recommend to the MCA to add this as a separate lecture. Where along with the integration we can take it.
Okay.
Okay. Thank you, ma'am.
Okay.
Thank you.
Thank you, ma'am.
Thank you, Dr. Thank you so much. So I'll move on to the few case-based discussions. Forgive me for the fallacies there because it was done in a haste. So just prepared a few. So this was the first one. 2-year-old girl is brought for elevated indirect bilirubin. A diagnosis is made and she's treated with phenobarbital, after which her bilirubin levels are lowered. What is the diagnosis? Why? Outline bilirubin metabolism. What are the types of jaundice? What are the hereditary hyperbilirubinemias? Define jaundice. Can it be used interchangeably with cholestasis? An image is shown below. What is the condition and what special stain will highlight this? Is it a little too much for undergraduates? I just thought it will probably cover that entire spectrum of hereditary bilirubinemias. Sorry? Because I thought that this kind of covers that PA 25.1 to a certain extent.
Dr. Tamil Selvi, you want to say something? Please unmute yourself.
No problem.
Yes, madam.
No problem. This can be included because nowadays NEET exam, they are asking too much of clinical scenario. They must know areas like this.
Okay, madam.
Can be included. Yeah.
Probably this is a shortened history, but probably we can add some more clues to it so that they get it right.
Yeah.
So I just quickly made it. We can probably add something more. Can I move on to the next one?
Yes, madam.
Yeah. So previously healthy 38-year-old lady has become increasingly obtunded in the past 4 days, feels really unwell. Her clinical picture is shown below. BP is 110/55. Lab evaluation is done. Details are given below. So clinical pictures and the lab parameters have been given. And the questions are this: what do you think she's suffering from? Give 3 main etiologies. What will be the morphologic findings in such a case? Why is the abdomen distended? Outline the pathogenesis for the abdominal distension. What is SAD? What is one other relevant blood investigation you would do for confirming the condition? What are the syndromes associated as complications? I've used it as a model for a liver failure. So based on that, all these questions. So kind of covering acute liver failure. And we can add and delete depending. I thought SAD, since it comes in the clinical scenario, at least they should be aware of what it is. and the hepatorenal and the hepatopulmonary syndromes. Any thoughts on that?
Anyone? Dr. Tamil Selvi?
No, ma'am, it's okay. Just carry on.
Yeah.
They should know. Yeah, it can be. We are making
Moving
us
on to the
to
next
read.
one. It is just to
Yes.
provoke a little bit of thought, stimulate thought. The next one is a 47-year-old woman presents with a recent history of dyspnea. She has no prior history of liver disease, is a smoker with a 30-pack per year, whatever. Reports drinking 3 to 4. She is overweight. Examination found to have ascites. Blood tests show the following. And they've given a few parameters. A photomicrograph of her liver biopsy is shown below. So what is the stain? What is it highlighting? Name 5 causes for this. What is the pathogenesis? What are the complications? What are the main clinical features? Name 3 other special stains used in liver biopsy. So kind of covering cirrhosis there. Any thoughts on this? I mean, each one can choose to add and subtract.
Yeah.
But
Yes, ma'am.
anything else that needs to be given? I thought this is a sufficient history to be given to undergraduates. Plus the picture is representative.
Yeah.
So
Okay.
can I move on to the next one then, if there are no comments on this?
Yes, ma'am.
Next one is, okay, this is just, yeah, a 38-year-old man feels acutely ill with nausea, upper abdominal pain, jaundice following a long weekend. On examination, there is upper quadrant tenderness. Lab evaluation showed total count of 16,000 with neutrophilia, serum bilirubin elevated, AST elevated, ALT elevated. A liver biopsy was also done. What relevant history will you ask? What is the pathogenesis of this? What is NAFLD? What is highlighted in the picture shown below? What is the clue in the investigations that will help you in the diagnosis? What is the dreaded complication in the long run? What are tumor markers? Name 2 new tumor markers which are useful in the liver. I just thought it covers alcoholic liver disease, alcoholic cirrhosis, carcinoma, and just a brief mention about what are the tumor markers that we can use for hepatocellular carcinoma as a thought. Any comments on this?
But this histopath picture is maybe we.
Mallory highlight. Yeah,
Yeah,
okay, fine. I
Mallory
can
highlight.
change that.
Yeah.
I use
Because
Mallory.
what happens,
Sorry.
madam, this is usually for postgraduate.
Fine. I can put a
Students,
picture
yeah.
of alcoholic
Yeah.
hepatitis and
Yeah,
ballooning
yeah.
and something.
Yeah.
Whatever. Okay, fine. I'll do that. Can I move on to the next one?
Yes, ma'am.
The image shown below is that of hepatitis virus infection, which has produced chronic inflammation. What is the virus most likely associated? Name the other hepatotropic viruses and the routes of entry. What is the serology for HBV virus? Which of these results in chronicity? And which one occurs as a super infection? There's a typo there. So I meant HCV because these are little clues that we tell them when they ask, when we teach them about hepatitis. So I thought based on that, we can probably format something on the lines of a viral hepatitis.
Okay.
Yeah.
Yeah.
Can I move on?
Yes, madam. Yes, Malini.
This will
Okay.
just some picture clues. So this is just to show the hepatitis B virus inclusion as a picture. So if they can identify it, and that is of high dated cyst. So that's it. Yes, this I thought can be used as picture clues. So you're just combining and relating everything and using it as a picture clue. Yeah.
Okay. Yeah. Anyone, any input, any thoughts on this? Anyone wants to say? Dr. Tamil Selvi, want to say something?
Yeah, ma'am. Okay, carry on, ma'am. Yes,
okay.
It's nice.
Yeah.
So I'm done with mine. So shall I stop sharing my screen now so that
Yes.
Dr. Vinaya, you can share your screen?
Yes, madam.
I'll just stop.
Yeah.
Okay, let me just quickly
Dr.
stop showing
Bedi,
screen.
so can you share my screen? Okay. Yeah, can you all see my screen? Yeah.
Yes.
Yeah, after the case based excellently done by Dr. Malini and SLOs, great effort, madam. I thought some MCQs pertaining to that, especially simple in viral hepatitis. These are the options given. Majority of cases acute hepatitis result in carrier state without clinical evidence of disease. They have to choose one best option. Here the answer is anti-HCV IgG does not confer immunity to hepatitis C. Then a young baby presents with jaundice, dark urine, pale stools. Most likely the problem is biliary atresia. What I thought all this because these students usually when we take exams of their during urine examination, I try to ask them bilirubin in which conditions in jaundice, how will you differentiate whether you get bilirubin in urine or no. Most of the times I see them confused, though they learn and come back, we teach them, they're always confused. So what I thought, when we are taking their lectures assignments, this can be given as an assignment, or like after the lecture we can give them as an assignment through Google form, and see whether they understand, and later on we can discuss this when the answers become wrong. So based on that, I've prepared some of these MCQs, so they understand the significance of each and every other option also can be explained to them. Third, regarding cirrhosis, like the options are: focal changes can constitute cirrhosis. Delicate tracts of type 2 collagen are deposited. Shunts occur in the rectum, esophagus, rectum. They all look more or less the same answer, but then the concepts will be clear. Like here, regarding cirrhosis, others are not. You don't get focal changes. The shunts occur in the rectum, esophagus, retroperitoneum, and falciform ligament. Then the dominant intrahepatic cause of portal hypertension is massive. The word massive they've used, fatty change. That is not the answer. So in that way, we can try to clear most of the concepts regarding this intriguing hepatobiliary system related to viral hepatitis and other lesions which we get. Regarding serum markers in hepatitis, IgM in HAV provides lifelong immunity. In HBV, HBE, this polymerase appear before HBs antigen. For that, they have to know the whole serum, which actually by horizontal integration, by that time, if they have already finished these viral markers in microbiology, and this can be reinforced through our MCQs. Carrier state in HBV is defined by the presence of HBs antigen. The one which is highlighted and underlined is the right answer in serum for 6 to 12 months or longer after initial detection. So then they can try to understand why the other options are wrong, so they will not get confused. The following are true for cirrhosis, except it is among the top 10 leading causes of death in Western world. The central pathogenic process is progressive fibrosis. It may be clinically silent, and alcoholic liver disease is the etiology in 30% of cases. So that is not right. Ascites is due to lymphatic obstruction, involves percolation of hepatic lymph into the peritoneal cavity, which is the right answer, does not involve renal retention of sodium and water, involves increased vascular permeability, is not associated with hepatic sinusoidal hypertension. So this they will know. Increased vascular permeability is a type of exudate. So that means it is seen in your exudate this. So that these concepts can be, as I said, they can understand, and they will reinforcement of their concept can also occur by giving this MCQs and assignments. This hepatitis C virus is a DNA virus, has core antigens, has serum markers, is a kissing disease. Persistent infection and chronic hepatitis are the hallmarks. Has a low rate of cirrhosis. Answer is persistent infection and chronic hepatitis are the markers of the hallmarks of the hepatitis C virus infection. Unconjugated bilirubinemia is soluble in aqueous solution, is not protein bound. When present in excess, is readily excreted in urine. Can cause kernicterus if present in excess of neonates. Is a major form of bilirubin elevated in gallstone obstruction? Answer is the D1. Can cause kernicterus is present in excess in neonates. Conjugated hyperbilirubinemia results from Gilbert's physiological jaundice, excess production of bilirubin, decreased hepatic uptake, cholestasis. Answer is cholestasis. With regard to jaundice, unconjugated bilirubin causes kernicterus in adults. Unconjugated bilirubin does not color the sclera. Unconjugated bilirubin is tightly bound to albumin. Unconjugated bilirubin produces bilirubin in urine, and conjugated bilirubin is tightly bound to albumin. So answer is unconjugated bilirubin is tightly bound to albumin. And unconjugated does color the sclera. So with these things, when we give, they are tend to make mistakes because it is very simple but yet difficult. Immediately it does not come to our mind how to answer. So as these are given as assignments in pre-formative and formative or just after the lecture, so the concepts of this lecture or this topic becomes reinforced. So with that type of assignments, these MCQs can be used. Hepatitis C infection is associated with sexual contact, carries 40% risk of cirrhosis, is idiopathic in 10% of cases, carries greater than 50% of risk of chronic progressive hepatitis. And few application based, I have done MCQs, case based, and here whatever right answer they may get, but they have to justify, give with explanation. So that again carries the same scope of reinforcement or understanding. And the other topics which we cannot cover up, like alpha antitrypsin antibody deficiency or Wilson's disease, can be taken through this and give us a scope, give us a entry, to start teaching them this. So which will, as Dr. Ajit said, help them in their PG NEET examination, which are usually such questions are definitely asked more. So it may help them. It will be like they are sensitized to all these things during when we are covering this topic of hepatobiliary lectures. A 42-year-old man experiences malaise, increasing ictus for 2 weeks. Physical examination shows jaundice, and there are no other significant findings. Serologic test results are positive for IgM anti-HAV, hepatitis A virus, and negative for anti-HCV, HBs antigen, and IgM anti-HBC. Which of the following outcomes are most likely to occur in this man? It's very difficulty. I mean, it's there. I mean, this may not be taken for their summative exams. Definitely, we'll use it as a classroom. This answer is B. B is that complete recovery. Detection of IgM anti-HAV indicates acute infection. Progression of HIV infection, hepatitis A virus, to chronic hepatitis does not occur, but few cases are complicated by fulminant hepatitis. And hepatitis A virus viremia is transient, so blood-borne transmission is rare, and HIV is spread usually by fecal-oral route. I just have 2-3 more cases, and here we have the history. A 40-year-old woman wishes to donate blood to help alleviate the chronic shortage of blood for transfusion. She is found to be positive for hepatitis B surface antigen and is excluded as a blood donor. She feels fine. There are no significant physical examination findings. Laboratory findings for total serum bilirubin, AST, ALT, alkaline phosphatase, and albumin are normal. Further serological tests results are negative for IgM, anti-HAV, and anti-HBC and anti-HCV virus. Repeat testing 6 months later yield the same results. So which of the following is the most appropriate statement regarding the pathophysiology of this patient's condition? A. Chronic carrier state with no therapy indicated. Clinically, overt hepatitis will occur within 1 year. Erroneous test results that need to be repeated. Hepatitis B vaccination series is now required. And infection acquired through intravenous drug use. The answer is A. And as I said here, this is just justification. We have to tell whatever answer you're giving, whichever, explain with justification. So the persistence of hepatitis surface antigen in serum for 6 months or more after initial detection denotes that person is a carrier state. Worldwide, most individuals with chronic carrier state for hepatitis B virus acquired this infection in utero or at birth. Only 1 to 10% of adult HBV infections yield a chronic carrier state. The carrier state is stable in most individuals. and they are so-called inactive carrier state without any elevation in liver enzymes, and some infected persons may eventually clear the virus. Currently, there is no therapy to aid this viral clearance. Vaccination is useful to prevent infection, but not clear the virus, although carriers become reservoir for infection of others. So by giving this particular case through blood donor donation, certain concepts of this can be, and maybe they will recollect and they will remember and help them. Out of this, A was the right answer. 53-year-old woman from southern China has had fever and right upper quadrant pain and jaundice for the past 6 months. On examination, she has an increased liver. Abdominal CT scan shows 5 centimeter right hepatic tumor with branching infiltrative appearance. The liver biopsy was performed, and on microscopic examination shows irregular invasive glands in the desmoplastic stroma. This patient is most likely to have chronic infection. So here again we can just tell them the which in neoplasia we tell about them the type of parasites and the tumors which it is associated. So through that, this particular case, we can show Clonorchis sinensis, Echinococcus granulosus, Plasmodium vivax, Mycobacterium tuberculosis, Salmonella typhi. The answer here is Clonorchis sinensis. Answer is A. Here they can explain parasitic liver flukes, or we can explain it to them if they are unable to say, are endemic to Southeast Asia. Infection may be asymptomatic for years, but then eventually they progress to chronic phase complicated by recurrent pyogenic cholangitis and jaundice. There is a risk for development of cholangiocarcinoma, which is the second most common primary hepatic malignancy. The other listed options fail to carry a risk for neoplasia. That is, echinococcus leads to hydatid disease, but not malignancy. The Plasmodium vivax infection has an extra erythrocytic phase in the liver. Disseminated tuberculosis produces granuloma, small and multifocal. And typhoid fever can be a systemic disease with liver involvement showing micro patch of focal necrosis. This is my second last. A 79-year-old man has had increasing abdominal discomfort and malaise for the past year. On physical examination, his liver scan is increased. His size is increased of the liver. His stool is positive for occult blood. Laboratory studies show hemoglobin 8 grams per dl. HCT is 22%, hematocrit. And total protein was 5.6 grams, albumin is 3.7. Alkaline phosphatase is raised, that is 209 units per liter. The representative appearance of his liver is shown in the figure. Which of the underlying condition is most likely to have? So here again they have to, it is like an application based MCQ, so they really have to apply whatever knowledge they have of the symptoms and many things. So in this, the answer is actually B, colonic adenocarcinoma. Out of the options, chronic alcohol abuse, colonic adenocarcinoma, Gilbert, hepatitis B virus infection, because all these nodules look multifocal and they have umbilication, which we generally teach them when we take here in the center. Some of the nodules are showing as if these are the demarcated, well defined deposits within the liver parenchyma, and that indicates yes, this is a metastasis, well defined nodules, and at the center you tell them to look at the central umbilication. So if they know this is metastasis or liver, then what are the options they are going to choose from here? So then it is B. The multiple masses in figure is consistent with metastatic carcinoma. Mets in liver are far more common than primary neoplasms. That can be told to them. We can discuss the answers with them. The microcytic anemia and the stool positive for occult blood suggest colon cancer. The mass lesions cause intrahepatic biliary obstruction to elevate the alkaline phosphatase, which is raised here in this case. The cirrhosis and the potential for primary HCC may ensue from either alcohol abuse or viral hepatitis, which sometimes you may get a dominant mass lesion there. And the Gilbert syndrome and other hereditary hyperbilirurinemias are unlikely to lead to malignancies. The metabolic syndrome, diabetes, increase the risk for NAFLD, NASH, cirrhosis, and HCC. This is the last case. A 41-year-old woman experienced increasing malaise and 10 kg weight loss in the past year. She becomes increasingly obtunded and lapses into the coma. Her serum alpha-fetoprotein is increased. The representative gross appearance of her liver is shown in figure. Ingestion of which of the following substances is most likely to have played a role in the development of this condition? Here we have acetaminophen, aflatoxin, aspirin, ferrous sulfate, nitrites, and raw oysters. So actually the answer here is they can, here looking at the gross, they realize there's a liver parenchyma and well demarcated one mass is seen. So that looks, it is a hepatocellular carcinoma or hepatoma. So with this, they should able to associate this hepatocellular carcinoma is, which you have taught to them during neoplasia, chemical or the fungus relating to malignancy. So aflatoxin plays an important role in that. So he can, the answer is B. Aflatoxin is an hepatoxin and is a product of fungus Aspergillus flavus, and which grows on moldy cereals. Aflatoxin can be carcinogenic, leading to HCC as shown in this figure. Ingestion of large amounts of acetaminophen leads to hepatocellular necrosis. So sometimes we do get massive to submassive necrosis due to hepatitis A and E viruses, and also due to drug related. So that can be explained to them. And aspirin has been implicated in causing Rey syndrome in children, which results in extensive microvesicular steatosis. Prolonged and excessive intake of oral ions rarely can cause secondary hematochromatosis. Nitrites have been causally linked with cancers in the upper GIT. Oysters can concentrate hepatitis A virus from the seawater and can get contaminated with hepatitis A virus with sewage, and eating raw oysters can result in HIV infection. So I thought these MCQs can be, this is so, I mean, any thought on this, madam, everyone?
Dr. Vinaya?
Yes, madam. Yes, Dr.
No,
Tamil
nice
Selvi.
MCQs. Yeah, it's really making them think. They may not
Yeah,
get these questions for the exam, but at least they'll have to stimulate a thought process, I feel.
Yes, madam. Means we did not give them for their summative exams or anything, just because we have so many things to teach them. Yeah.
True.
Madam, Shagufta madam?
Yes, Dr. Lanjawar, sir. Dr. Shagufta, Dr. Lanjawar. Yes.
Hello.
Yes, sir.
Everyone has done their job very nicely. I congratulate everyone. Inputs were also very good. And this MCQ of Vinaya, very high standard.
Yes,
very
I know, sir, but that's why I told sir not to keep them for summative exams, sir. This is, because then at least with this we can try to teach them some concepts during our small group teaching. That way, or after all the lectures, so we can take this assignment in MCQs, but then they will get 10 wrong out of 20. Then we can explain them why it is wrong. That's all. So it is as a way to get to them, or kuch nahi, sir, because it is really very hepatitis.
They are very good, and students will be benefited.
Yes,
and besides MCQ, they have to read.
Yes, they have to read. Yeah.
Teacher has to read.
Yes, teacher also has to read. I agree, sir. So this I just made it in the morning. I had still many these cases.
Okay,
I thought,
good.
Yeah,
Good. Keep doing that so that we are also stimulated to read.
Yes.
Thank you, sir. Sir, actually, I have prepared some groups, because now this Friday we'll see whether we can have SLOs on male genital and dermatopath together. Dr. Tamil Selvi was thinking we'll do that together, of course. I don't know.
Yes, ma'am.
I'll be coordinating with Dr. Tamil Selvi. And now I have prepared some other groups, actually hematology. Then you have female genital tract. So for the next week, Tuesday and Friday, So we can start
Yes.
working on that. So we can have those 2 system SLOs next week. So I have prepared one group on female genital tract and one more lymph nodes and hematology. And already people have joined there. So I think so from there we can go ahead and start doing SLOs and case-based, etc.
Hello.
Hello?
Ma'am, today the nice presentation all of you have done,
Yes.
and questions are excellent, ma'am. It is making
Yeah.
brain to think and answer for the questions.
Yes,
Hepatitis
yes,
somehow, however you read and you take the class, whether they
Yeah,
understand, so that is very, very difficult.
yeah,
So if
yeah,
you
yeah.
understand and go through again,
Yeah,
then only they
we
can
as
understand.
yes, madam. We
Yeah,
as
that
teachers, we
questions
also
was
have to
nice.
go through it.
Yeah,
Yeah,
yeah, very nice
because for them
questions.
to understand the concept why that bilirubin
Yeah,
comes in urine, because it is
yes,
conjugated. So
yes,
why
yes.
it is conjugated and so it really, I agree, madam.
Okay,
Yes.
excellent presentation.
Thank you, ma'am.
Yes, thank you, ma'am. Thank you, sir.
Thank you.
Thank
Thank
you.
you,
So I think
Dr. Malini, very much
Thank you. Thank
for the giant effort you have
Thank you.
taken to prepare the SLOs at the last minute, madam. Thank you so much.
yes,
No worries. A lot of help was also there. Yeah.
yes,
Thank you.
and
Shall we
all those
wind
who
up then?
participated, Dr. Nambiar, Dr. Barnek,
And Dr. Shagupta, thank you so much for your input, madam. Dr.
Dr.
Ajit,
Shagusta,
thank you
are
very
always
much.
there. Yes.
Nice to hear from you, Dr. Ajit.
So now gradually a compilation effort will also be there. Dr. Vinaya will be taking the I must thank Dr. Vinaya also. She has uh, started leading very emphatically. So the group is moving now in the right speed. So
Because yes, yes, sir, I agree. Because actually, what is happening now, we have very less time. The lockdown will ease out now, and there is some
yes,
exams. CBME, the new batch, the exams are going to be held in September. So I think so.
yes,
We may get them in October, November.
yes. So we should, and they have asked us to send those these by I think end of August.
I don't know that we have to see, sir, what MCI said. I'm not aware. I'll find out. I don't know.
They are not given a
Because
date, but the work has started.
actually, we also have to upload the timetable, sir.
Yes,
Majority,
yes.
they,
That we also have to create.
yeah.
Okay.
Thank you, sir.
Okay,
Okay. So
thank
I'll
you.
correct get the look and
Thank
send
you
it to
very much.
Dr. Bedi, right?
Yeah.
Yes.
Fine. Okay. Thank you.
Thank you.
Thank you.